The next defect is single ventricle, which represents less than 1% of congenital heart diseases. In this defect, both tricuspid valve and the mitral valve are connected to a main single ventricular chamber. This chamber, in turn, is connected to another smaller rudimentary chamber through what we call a bulboventricular foramen. It's something like a VSD. One great artery, whether pulmonary or aorta, arises from the main chamber and the other arises from the rudimentary chamber. In 80% of cases, this main chamber is usually the left ventricle, what we call a double inlet left ventricle. This defect is associated with malposition of great vessels in 85% of cases, pulmonary stenosis or atresia in 50% of cases, and aortic arch anomalies in some cases. The bulboventricular foramen, which is a VSD, as we said, is usually obstructed in nature. Sometimes there are abnormalities in the mitral or tricuspid valve, whether it is stenotic or overriding or straddling. In this disease, there is usually mixing at the ventricular level. However, the saturation is determined by the pulmonary flow according to the presence of pulmonary stenosis or atresia. If it is present, then there is decreased pulmonary flow with cyanosis and saturation less than 85. If the pulmonary valve is atretic, this represents always by birth. If the pulmonary valve is not stenotic, then the pulmonary blood flow will be large, and there is signs of congestive heart failure very early in life, and saturation is usually above 90%. Clinically, these patients will develop by variable degrees of cyanosis since birth. If there is increased pulmonary blood flow, there will be history of congestive heart failure manifestations like failure to thrive and repeated chest infections. By physical examination, it depends according to the magnitude of pulmonary blood flow. If there is increased pulmonary blood flow, there will be mild cyanosis, maybe unnoticed, manifestations of congestive heart failure, and growth retardation. The second sound is usually single and loud. There may be a long systolic murmur of the relative pulmonary stenosis due to overflow across the pulmonary valve. There is the systolic murmur of the pulmonary regurgitation as a result of pulmonary hypertension. With decreased blood flow, there is moderate to severe cyanosis. There may be clubbing in older children, single loud second sound, ejection systolic murmur of the pulmonary stenosis. ECG shows unusual ventricular hypertrophy pattern with similar QRS complexes all over the pericardial leads. So there is no pathognomonic right ventricular or left ventricular hypertrophy manifestations because there is no differentiated ventricle. There may be either first or second degree AV block. Arrhythmias may be occurring in ECG tracing, like SPTs or wandering pacemaker. Chest X-ray may show either increased heart size and pulmonary vascular markings in cases of increased pulmonary blood flow. In case pulmonary blood flow is normal or decreased, the heart size is normal, and the pulmonary vasculature is either normal or decreased. Echocardiography is the most important diagnostic sign with the presence of a single ventricular chamber with two AV valves opening into it. Other studies include cardiac catheterization if needed preoperatively to assess the pulmonary artery pressure and the size. So the natural history of these patients, if left untreated, Patients without pulmonary stenosis, there is congestive heart failure and growth retardation. 50% of these cases will die before the age of 1 year. If there is pulmonary stenosis, cyanosis will increase by time with worsening of PS. Initial medical management of these cases includes prostaglandin 1 infusion in cases with severe pulmonary stenosis, pulmonary atresia, also in cases with severe coarctation and interrupted aortic arch. In patients with congestive heart failure, anticongestive measures will be required. Clearly, this patient is called single ventricle, so it's going into a single ventricular repair pathway. First of all, we should do initial palliative measures to make sure that the patient is ready for the first surgery, which is Glenn. At first, if the patient is having severe pulmonary stenosis or pulmonary atresia, a BT shunt may be required to improve the oxygen saturation. If there is increased pulmonary blood flow, a pulmonary artery bending may be indicated to prevent from developing pulmonary hypertension and pulmonary vascular disease. Also, any aortic arch pathology should be addressed at this period. After the age of 3 to 6 months, this patient is supposed to go for a Glenn shunt. And finally, by the age of 30 years, the patient should go for the definitive surgery, which is the Fontaine procedure.